Hello, Miss Scholars. I'm happy to be joining you today. I wish I were there in person. I'm Lynn Madden. I'm an assistant professor at Yale University School of Medicine and a colleague of Dr. Altice. I'm also the chief executive officer of the ACT Foundation here in New Haven, Connecticut. I'll talk today about using the network for the improvement of addiction treatment as a convenient and powerful approach to improving healthcare delivery. NIATx, it's important to point out, was originally a partnership formed in the United States of two grant-funded programs in 2003. One of those programs was representative of the United States federal government. It's called Strengthening Treatment Access and Retention, and it was paid for by the Center for Substance Abuse Treatment. The other was the Robert Wood Johnson Foundation, a private philanthropic organization. And it was rather unusual for a private philanthropic organization to join forces with a governmental organization to fund a particular implementation approach. And we've learned a lot since that time period. So when we think about implementation science, the key to successful implementation is actually facilitation. What we're trying to do with NIATx is bring a guided facilitation approach to the process of implementation. And when we see here that effective implementation is almost always guided by effective use of implementation science and practice, particularly the process of facilitation, which again, NIATx is highly focused on. So in an effective environment where you have an evidence-based practice and there's expert facilitation, there's about a 3-year gap between science and implementation. In an environment where you just let it happen, where the science gets put out there and there is not effective and expert facilitation, that gap is about 17 years. So we're trying to close the no-do gap. And here's another way of actually looking at that. What we know gets spread more quickly by what we do. So NIATx is embedded in some essential, NIATx is embedded in learning collaborative thinking. So these are the essential learning collaborative components here in front of us. This comes from the work of the United States Institute for Healthcare Improvement. And the steps are pretty straightforward. So you have expert or collective expertise that develop a collaborative goal and framework together. They establish faculty and teams at the local level. So that may be an agency, it might be a state, it might be a region, but teams at the local level are formed. There's pre-work that goes into all of this, in which the activities and conference calls take place. There's some understanding of the actual goals. There's agreement among the expert panel about what the aims actually are. So one very important component of thinking about implementation is to understand what one is actually trying to accomplish. What is the aim? What is the goal? Once that is established and expertise is brought to the table to help facilitate that goal, we bring together a series of learning collaboratives. And generally speaking, they take place over an 18-month or 36-month time period. So you have 3 sessions over that time period with action periods in between them. The action periods are enhanced by the use of PDSA cycles, plan, do, study, act cycles. This is where NIATx comes in. And then ongoing implementation is supported by conference calls, collaborative internet meetings, monthly data and metric meetings, and ongoing facilitation and coaching. This comes from a systems thinking orientation from the work of W. Edwards Deming. And the starting assumptions are that everyone is acting as they should, given the system they are in. Your current system is perfectly designed to produce the results it is currently producing. To produce different results, you must change the system. So there's a lot of nice things about this assumption, but one of the things about this assumption that I really like is that it assumes good intentions, right? We are not looking for bad people or people who aren't doing their work well or people who aren't committed. We're actually looking for ways to come together around an aim right? It assumes competence. It assumes people are doing the best they can inside the system as they understand it. And we're looking for process changes in particular that might move us toward the goal we have collectively set. That goal may be to have more people identified who may have HIV. That goal may be to move more persons who have been diagnosed with HIV to ART. The goal may be to improve the number of people who stay on ART and ultimately have a suppressed viral load. So why process improvement? Well, people are actually served by processes, and we're going to talk more about this. There are tools that can help us identify which processes might be most amenable to being shifted. 85% of customer-related problems are caused by organizational processes. In other words, perhaps it's really difficult to call into the organization and make an appointment. Maybe people go to a voicemail over and over again. Maybe their call is not returned. Perhaps they don't know how to navigate between one piece of the system and another piece of the system. Those are process issues. So to better serve our customers, organizations must improve processes. This is based on 5 key principles. So this is the science that really underlies NIATx. These are evidence-based predictors of change. They come out of a factor analysis of the organizational change literature, in which 84 factors that predict change were rank ordered. And essentially, the 5 principles that stand out are these: understand and involve the customer. The customer may be the person that we call patient. The customer might be a healthcare organization itself. The customer might be the staff of the healthcare organization. But first and foremost, it's important to understand and involve the customer. Secondly, we want to focus on key issues. What is the real problem? Perhaps the real problem is we have people identified as having HIV, but we don't have a proportion of them that we would like moving on to ART. So you want to focus on the real problem, right? One problem at a time. Inside whatever change team is formed or organization, we want to select the right change agent. And we'll talk a little bit more about what that means. Importantly, we want to seek ideas from outside the field and outside our own organization. What have you seen work in other places? How do you think you could apply that to the field that we're talking about today? And lastly, and also critically, do rapid cycle testing. So we're not trying to plan implementation over many months or years and sort of drop it down on the system. Rather, what we're trying to do is identify what opportunities we might have to move toward the goals that we have and test them one at a time. So the ultimate solution becomes iterative. We learn a bit more every time we do a change cycle. Interestingly, understanding and involving the customer from a factor analysis perspective outweighs these other 4 evidence-based predictors of change altogether. So it has more endorsement in the literature, understanding and involving the customer, than the other 4 evidence-based predictors of change added together. So what do we do with this information? Well, we conduct change exercises, and they're very straightforward. We plan the change, we do the plan, we study the results, and we act on the new knowledge, right? So P.D.C.E.O. These are rapid cycle changes, which is an innovation. Changes should be doable in a 3 or 4 week time period. So you're looking at small changes, one change at a time. We plan a change based on local baseline information. And we're going to talk about how that information is developed. So plan a change, do the plan, study the results, and then act on the new knowledge. Keeping in mind that you want to choose a change that's small enough from an implementation perspective to be doable in a 3 or 4 week time period. What we see is that we need multiple change exercises, one following the other, that result in improvement. So we take our hunches, theories, ideas, our baseline data, and we turn them into change cycles that we test for a relatively short amount of time, 2 to 4 weeks, Then we look at what we've learned from that, and we decide how we're going to move to the next change or what the next change might be. So plan the change using information that you have, do the plan, study the results. This is the important piece. Before you act on the results, you have to see what you've actually learned, right? Did the change move you in the direction that you want to be moving in? So these are essentially yes or no, simple data questions. Are you moving in the direction that you want to be moving in? If so, do you want to adopt the change? Do you want to adapt to the change, which often happens? This is moving us along, but here's something that might move us along a little more. Do you want to adapt the change, or do you want to abandon the change because it isn't, in fact, moving us in the direction that we want to be moving in? So one way of thinking about collecting local data is to conduct a walkthrough. What's it really like to try to use the services that you're trying to actually shift? What is that really like? So a walkthrough is a very important way to build baseline data. So we want someone to play the role of a potential client and perhaps a client friend or family member seeking treatment. Try to think about and feel as the client family member would. Think about what they might want to have changed. Ask the staff what changes might make the process better for clients and for themselves. And then compile a list of client and staff needs or opportunities and possible improvements that could address these needs. So remember, when we looked at the 5 evidence-based predictors of change, first and foremost was understand and involve the customer. This is one way to get a sense of what the customer experience might actually be like. This is baseline data. So rapid cycle change, these are the breakthrough innovations of NIATx. Rapid cycle change appeals to both logic and emotion because we get information essentially in real time, 2 to 4 weeks, and we're acting from information that we've built ourselves using the walkthrough as an opening experience, as well as other kinds of ways of building baseline data that we're going to be discussing, such as nominal group technique and flow charting. That appeals to our logic. People are involved. It appeals to their emotion. There really is something that you can do about a problem or an issue that may feel like you've been working on it for a long time. This is a way of thinking differently about how to change and move toward the aim that you've set as a group or an organization. In addition, you have a business case or a clinical outcome case or both that ties the change to strategic advantage. So in the case of HIV, there is a real clinical outcome improvement in having people who are identified as positive for HIV move to being on ART. That's a clinical outcome case. In some organizations, this may also be a business case because of the way that they're paid. So starting a change project, pretty straightforward before we move into an example. You select a change team, name a change leader, name an executive sponsor, and a data person. So those are 3 important roles on a change team. You conduct a walkthrough. What's it really like to be that client or customer? We collect baseline data. We use nominal group technique. We use flow charting. We use the walkthrough. You review the baseline data that you have. You may have some data about what the gap is between identification of HIV and initiation of ART. What is that gap? That is your baseline data. Suggest a process change that might move toward the desired aim, right? So these are the 5 steps of starting a change project. And here is a quick case example. APT Foundation is an organization that serves people with substance use disorders and mental health needs, wanted to improve both access to care and retention in care as the first steps in improving both clinical and financial performance in the organization. So methods proven to increase access to treatment are informed by identifying and eliminating the barriers that prevent people from readily accessing services. This is the value of a walkthrough, for example. Retention is improved by shifting programs to be more reinforcing in the belief that, and the science bears this out, that clients come back if the program is engaging to them and includes evidence-based care. Both aims are achieved by making changes based on consumer feedback. People vote with their feet. Are they coming into the organization? Are they moving through the stages of care that are in their best interest? So we can measure all of this. This is gained through organizational level data. So here's an example for you. At the App Foundation in June of 2006, after we saw a person and identified that this person had a substance use disorder, it took 21 days on average for a person to receive medication that was already prescribed to them by the organization. So 3 weeks. And when you're thinking about people who have a substance use disorder, 3 weeks is a long time. Most of these people were actually lost to care. So we took on trying to understand what the barriers were to more timely treatment. How could we get people in right away? By June of 2007, we had done about 7 change projects. We had moved that average time to treatment to just under 8 days. And then by June of 2008, we moved our initial appointment with people to walk-in evaluation. So a person no longer needed to make an appointment, which was what was getting in the way for many people, keeping that appointment that was off into the future. So we moved to all walk-in evaluation. And today we actually have access to care on the same day. So people are admitted to treatment on the same day that we see them. Here's what happened to census simultaneously. We moved from about 1,673 people in July of 2007 to having 3,433 people in June of 2014. And this work is ongoing. So this is work that you can continuously engage in. Today, we have 4,500 people in treatment with us with opioid agonist therapies. So one of the questions that came up very quickly from our clinical team was a question about whether rapid access was really working. So great, we're letting folks through the door really quickly, same day. That means people's roles inside the organization as staff may have shifted. We were putting a very big emphasis on the front door, making sure that people were evaluated, that they saw a physician, that they had a physical if that was needed, that they had their blood work done. All of those things happened on the same day. So you can imagine that the way the organization worked shifted, but it shifted one process at a time. The staff began to ask, was rapid access working? So that's a fair question. And so we used the Basis 24 to try and answer that question. This is a very brief client-centered self-report of symptoms. It's highly well-validated, and it scores people in these domains: depression and functioning, relationships, self-harm, emotional ability, psychosis, and substance use, and then an overall score. So we're letting people in really quickly. How is that going? Is that really working for them? So we did an analysis of 2,529 patients. We did CTAsst comparing admission scores before we moving to open access or same-day admission and after centralization of open access in July of 2007. We repeated measures ANOVA on baseline to midpoint before and after the intake change. So that's really the method that we used here. These are the participant characteristics. And what we saw is that as time to treatment declined, more clients entered treatment, right? So time to treatment, I showed you that graph that showed time going down as a barrier to treatment and census simultaneously climbing, which is what we're looking for. Barriers to access were systematically addressed and ultimately included bundling all services needed for admission and diagnosis on the same visit. This first day that you walked in, you received all services that you needed in order for a diagnosis to be made. If you were a good candidate for a medication, you were prescribed the medication the same day. There was no waiting period. We did more than 10 change cycles to move toward that particular aim. Those who entered more quickly were actually more acutely ill, as you'll see on the next slide. However, they gained as much improvement as their less acute peers. In other words, more people received more, became better as ACT improved access. So as the census grew, we also reduced our reliance on grant revenues, which are often less stable, perhaps. We reduced our reliance on grant revenues from 54% to 22%, and then have achieved increasingly positive margin. So here's just a quick look at the basis 24 subscale differences. You can see on the left-hand side the standard intake. You can see depression and functioning in the red, for example, relationships in the yellow, self-harm in the green bar, emotional lability in the orange bar. The pink bar is psychosis, the gray bar is their substance use scale, and the brown bar is the total. So what does that really mean? So you can see again here, the standard intake, we're taking a look at depression and relationship problems over time across intake procedures. So again, the standard intake being on the left, here's the access intake. So you can see when you look at the access intake that the red bar is higher. People are endorsing more symptoms of depression in the open access condition, but yet their depression is declining as well as their less acutely depressed counterparts in the standard intake. We see the same thing in the relationship subscale. So changes to open access intake were really related to higher severity of total score. Right? So significant reduction in severity from admission to the midpoint and all 6 domains. So people got better in a statistically significant way in their severity from admission to midpoints in all domains, all 6 basis 24 subscales. Open access intake, and that's in both conditions, both in open access as well as in the previously more standard approach to making appointments. The open access intake had higher admission depression scores than standard intake, but no differences at the midpoint assessment. So what that means is people came in more acutely ill. They may have been people who previously would not be able to navigate the complexity of waiting longer for admission, but yet when we let them in immediately, they got as well on the depression subscale as their less acutely depressed counterparts. The standard intake had higher admission relationship scores, but no difference at the midpoint assessment. So what this shows is that open access increases census. It also, in this particular situation, was able to be offered to people who were more acutely ill as measured by the basis 24, yet those persons were able to get as well as their less acute counterparts in the same amount of time. So what are we really looking for in a very simple world of thinking about improved access to treatment or improved movement along a particular continuum? We are looking for services that people can and will come to, that we can pay for and that work, right? So this is the triangle that we're thinking about, services that people can come to and will actually come to, that we can pay for and that are effective. It's important to use transparent metrics that are understandable to your payers, to your clinical teams, and to clients to evaluate service offerings and improvements. So when we think about plan, do, study, act, the study phase is really important. What do those data look like? Initially, what you're looking for are performance metrics that are process-based. Did more people come? Did more people stay? Did more people move to the next level of care, right? So really simple questions. Under the hood of all that, we're always looking at our clinical quality. I want to spend just a few minutes switching gears and talking about a walkthrough as an opening experience. And then we'll wrap up by talking about really how to form change teams and what critical roles are necessary there. So a walkthrough is an exercise where staff members walk through the treatment process just as a customer does, as we spoke about before. The goal is to see the agency or the organization from the customer's perspective. Taking this perspective of treatment services from the first call or contact for assistance to the intake process and through discharge or movement to another level of care is the most useful way to understand how the customer feels and to discover how to make improvements that will serve the customer better. So here are some steps for conducting a walkthrough. You want to select a couple of people from your organization, the role of client or customer and trusted or significant other. The two of you will need to be detail-oriented and committed to making the most of this exercise. To ensure that your experiences will be realistic, make sure you present yourselves as dealing with an addiction or a medical clinical problem that you are familiar with, and therefore able to consider the needs of people with these particular issues. So let the staff know in advance that you will be doing walkthrough exercises. This is not a secret. And although you might get the absolute best experience by doing that, it is far better to include them than to go behind their backs. Even though you get the best experience, you will still find opportunities to potentially improve the experience. Go through the experience just as a typical person would. The walkthrough should begin with the first contact. Is that a phone call? Is that walking in? Is that showing up in an emergency department? And extend through at least the third visit. Try to think and feel as a client or family member would. Look around. What are they thinking? How do you feel at any given moment? Do you know where the bathroom is? Are you able to ask questions? How are you treated? So although we're looking for objective places where you can suggest process changes, we're also looking for your subjective experience. What is this really like to be this person? What's it like to potentially be a customer? At each step, ask the staff to tell you what changes would make it better for the client and what changes would make it better for the staff. Write down their ideas, write down your feelings as well. And then finally, between the two of you, the client and the trusted other, write down a list of the needs you found and the improvements that could be made to address these needs. What are the real opportunities here, right? Be sure and address what the needs may be from both the client and the staff perspective. So again, you're not looking to make this a secret. You're looking for improvement opportunities to move toward the aim that you've set as a collective group. You're including the staff and making it clear to them that their opinions are important. And then ask yourself, what surprised you most during the walkthrough? What two things would you most want to change? Remember, the walkthrough is one of the ways to gather baseline data. And other ways are nominal group technique and flow charting, as well as actual quantitative data that may be available to you at the site or generally from a regional perspective. So you want to ask yourself, what two things surprised you most during the walkthrough? Those may be the basis for thinking about opportunities for improvement or opportunities to leverage pieces of the situation that are already going really well. So what two things would you most want to change? So that's a very quick look at the steps of the walkthrough. But I think using the walkthrough as an opening experience is one way to get at that fundamental evidence-based predictor of change, which is to understand and include the customer. So as we move into thinking about key roles and starting a change team, you have a couple of key roles as we've spoken about. We have the executive sponsor. This is the person that provides vision to the project, provides a clear link to a strategy. What's the aim here? How is that embedded in the strategic plan of the organization or the region or the country? You want to set a clear aim for the change project, right? Clearly try and understand what you want to do. So saying we want to improve the cascade of care is a great vision, but that's not an aim statement. The aim statement would be you want to improve the number of people who are diagnosed with HIV who move into treatment with antiretroviral therapy. So, and we would like to do that in a 6-month time period, right? So you want to set a clear aim statement. What is the aim of the change project? There may be other worthy aims. but each change project needs its own specific aim that you can plan, do, study, act around, and ask yourself over and over, are we moving in the direction that we want to be moving in? So the executive sponsor is also responsible for engagement. This person supports the change leader, periodically attends the change team meetings, doesn't have to go all the time, and personally invites change team participants. So if you'd like to set up a change team in your organization, you may select, let's say, 5 or 6 people, certainly no more than 9 people. We don't want these change teams to be too large. The executive sponsor might write a note, dear staff person, we are working on improving the number of people who move from HIV identification to antiretroviral therapy initiation. Would you please join this team? We'll be working on this goal for the next 6 months. And the first meeting will be on July the 1st, 2022. So personally invite change team members, make their participation time limited. You may, in fact, choose to continue their participation, but it also gives you the latitude to perhaps have their term on the change team and another person take their place over time. And then the executive sponsor provides leadership. You have to be committed to the aim. You need executive authority to do that. The executive sponsor may have the ability to remove some barriers to change, for example, for in a short time, maybe over a pilot project link, really allowing a policy to be tested. That isn't necessarily the policy that exists in the moment. Executive sponsor helps the team to connect the dots. This is how what we're doing is actually related to the goal that we have, and communicates clearly, concisely, and constantly. And we'll see how that communication moves throughout the change team. You're looking for the right change leader, someone who is very committed to the change. So what you don't want in the change leader role is a person who doesn't really like change. And we all know some of them. But that's okay. There are plenty of great people who aren't particularly liking of change. But we want to look for in the change leader role a person who's committed to making change. The change leader needs to have some influence and respect across levels of the organization, a direct line to the executive person, empathy for staff, and enough time devoted to leading change projects. Right? So this is a person that is a go-to person that will get the job done, that will keep the momentum moving. So these are the leadership characteristics of change leaders. This comes right out of NIATx. This is Change Leader Characteristics Survey, and we had 99 responses here. So the top issue that came up, the top characteristic that comes up here is a person who challenges the status quo. That might be somebody who's constantly asking, like, why do we have to do it like this? Or couldn't we try that? I know this is the way we've always done it, but it isn't really working for us. So what ideas do we have to make it different? We need a person who is willing to move forward with results verified by data. So important in that plan, do, study, act phase. The hard part sometimes is the study phase. When you get to the data, are we really committed to doing what the data suggests we ought to be doing? Change leader needs to be persistent. Some change projects won't work. We need to be able to say that doesn't matter very much, right? Data is just data. And now we know that particular process change that we suggested is not the one to move us toward the aim. What are we going to try now? So somebody who is persistent and is respected by members of the organization. And lastly, a person who focuses the team on objectives. Let's come back to what we're trying to accomplish here, because many of the issues that confront us as we try to do improvements in healthcare systems, many of the issues are very complicated. So part of the beauty, really, of this particular implementation approach is that we're focused on a particular aim that is related to our larger vision. And the aim may switch from time to time, but only with leadership buy-in. So these are the characteristics that we're looking for as we think about change leaders. We need a data collection plan and a data coordinator. Data is your friend. Without the data, there's no way to tell if a change is working. Data should be simple at least change cycle data, clear and in real time. Great math skills are not needed. We'll do some analysis later on, just patience and reliability. Did more people show up, right? So really straightforward data that we collect in real time to really test the change cycle. We already know that the evidence-based practice that we're trying to implement is supported by data. So we're not trying to prove that again. We're trying to implement an evidence-based practice. And then this person has to have permission to actually gather the data, no matter who has it. So sometimes organizations have kind of like guardians of the data or secret data. We're looking for a way to measure our process changes. And so the change team needs to actually have access to the data. So leading change teams, you want to establish direction with a clear aim, create a sense of urgency. This is an important problem. Provide some accountability, involve the right staff, communicate all through the organization. The people on the change team should be aware, not on the change team, should also be aware of what the aim is, right? You want to engage senior leaders, motivate and inspire, and commit to empowerment. So create a process for short-term wins. This is why we focus on an aim with small incremental changes, one step at a time. Make sure and communicate what happens there. What do you learn from those changes? The change team responsibility, meet regularly, ensure accountability, make sure you keep minutes, identify potential solutions, quickly test one idea, measure the impact of that change, and then move on. What are you going to do next? Rapid cycle testing. This is 2 to 4 weeks. We want to start by asking ourselves 3 questions. What are we trying to accomplish? What is the aim? How will we know a change is an improvement? And changes can we test? And so we can brainstorm our way into those changes. Before making changes, collect baseline data. Again, the quantitative data you have available to you. The walkthrough data from nominal group technique. Dr. Altiz will be leading a workshop later this week to talk about nominal group technique, and flow charting that will also be included in the workshop that Dr. Altiz is leading. So collect baseline data, determine the target population and location, establish your aim, and select the change team. Remember, plan the change, do the plan, study the results, act on the new knowledge. You're going to adapt, adopt, or abandon 2 to 4 week change cycles. Here's some common detours. Projects not related to the goal. No feedback to the change team. Insufficient leadership. So the leadership moves on to something else that's also a priority. No business or clinical case, or choosing a change that's too large. These are common detours. You can fix all of these things. And if you find that your projects are not resonating, you're not getting the kind of understanding and implementation results that you may want, you can go back to these detours and ask yourselves as a change team, which of these may actually be occurring. Don't forget, small changes really matter. For support, you can go to the NIATx website, niatex.net. For questions, email each other, colleagues. If you become involved in a change project, we put all of the coaches and colleagues in contact with each other. So to start a change project, select a change team, name a change leader, executive sponsor, a data manager, conduct and review your walkthrough, conduct and review the baseline data, suggest a process change to improve access, for example, by using nominal group technique, and fill out the first page of the change project charter. So with that, we will be sure to make these slides available to you. We will sure to make these slides available to you. And I appreciate your time. I wish I were there with you this week, perhaps next year. And please attend the workshop that Dr. Altiz will be hosting if you have more interest in this work. Thank you.